before I come to the podium, I just want to comment on Aghyad's thing. I'd like to add one more way to embolize. Last year, we reported on endovascular ablation of the varicocele and of spermatic and ovarian vein. Now we have a series. Hopefully, we'll present it next year at Pairs. We have up to 40 patients with that technique, and that's one way to add. The other thing is the urologist will send you patients after they fail the first or the second time. Not the
what, sorry?
The urologist will send you patients, but only after their surgery fails first or second.
Well, this is it. This is it. By the way, the laser, the heat effect is not new. Laser, of course, is much more focal heat. But there were several publications in the past about using hot contrast for inducing thrombosis in the vein. I mean, no one uses it these days, but laser is more effective.
Dr. Sam, go ahead.
Thank you very much. It was very informative, and I enjoyed it. Safina Varix is one of the clinical entities or findings you can find or you can see during your practice in varicose vein surgery. It's infrequent, usually mentioned as one of the differential diagnoses of the groin swellings, usually mistaken with the femoral hernia. However, if you have a case about 4 to 5, maybe more in diameter, 4 to 5 centimeters, are you still going to use the radiofrequency for it?
I'm sorry, I did not hear the question very well.
Okay, I repeat it in a brief. Safina Varix, 5 centimeters in diameter, flush with the femoral vein, no neck. Are you still happy to use the radiofrequency, or use combination of things or hybrid procedures?
To be honest with you, I will see how easy it is to be able to compress that vein around radiofrequency or laser fiber. You can easily protect the femoral vein.
There is no neck. It's flush.
Well, there's a junction. There's a junction there.
The junction is 2 centimeters and incompetent, and the Safina Varix is just like on the vein.
Yeah, I tell you what I would do. I will approach it by compressing the femoral vein in a longitudinal manner with ultrasound. Everything, basically, I'm going to put my probe in a longitudinal way along this femoral vein. This way, I kind of like isolated it one way or another. I will puncture the varix from its lower bottom, okay? And here you have a choice of using many things, but I will still give enough tumescence anesthesia to really compress that varix completely around the RF or laser fiber, and probably bump up the laser power to 14 watts and burn it. And I think, we've had, not close probably as much as you described, but we've seen venous aneurysms from venous insufficiency that are very similar to the situation you're describing. Now, the femoral vein is not going to thrombose unless you actually hit it with unless you damage its endothelium one way or another, and you can still protect the femoral itself by basically compressing its entire trunk at that level. As long as you're compressing well and you're protecting it from the heat happening next door, I think you should be fine. Now, I wish I had an ultrasound image of what you're describing, but I still can find a way to treat it, because the other alternative is going to be surgical resection, and that's going to be a little more difficult to do.
Why? Why it is difficult to do?
Well, I mean, it's doable, but you're going to have to dissect the groin. You're going to have to dissect it from the femoral vein and suture the femoral vein. Correct me if I'm wrong.
This is my job.
We're talking about endovascular technique, but I mean...
Can I just one more thing. What I'm thinking about is just explore the vein, clamp it, suture it, and do a radiofrequency after this, and that's it.
And do a radio, basically dissect it. That's another good way, but we defeated the purpose of endovascular technique here. We've gone into surgical hybrid procedure, but then again, that's also possible.
Dr. Ali?
Can I just comment? Sorry, about this also I used to refer before when I started the tortuous great saphenous vein to surgery. Very tortuous, you cannot thread the laser, and they're very tortuous. And then I had actually a couple of cases where the lady refused surgery. So you have to also see, we don't want to get difficult cases, but also patients sometimes, they said, I'm here, I don't want surgery, I don't want anesthesia, and she also have elderly. And I tried the ultrasound-guided foam sclerotherapy. And I tell patient, you're going to need not one session, you're going to need maybe 2 or 3 sessions of ultrasound-guided foam sclerotherapy with high concentration, maybe 3% polidocanol or fibrovane. And I had good result because I did them twice. The result was good. They had thrombosis, and we managed to make them, not to go to surgery. So, things differ from, also the cost matters, but now I think there is a lot of tricks to help patient, without surgery.
One comment about tortuous saphenous vein, actually, I didn't mention this in my talk, is you can still, on the fluoroscopy sometimes, get into the vein, just as if you're doing the regular, below knee approach, and then using a glide wire, try to find your way all the way up to the femoral vein. You will be surprised that the vein is going to straighten up immediately, and then you can put your catheter and then your laser fiber and treat it as a regular ablation.
Dr. Ali?
Probably is the same line, Dr. Abbas. What would you do, what's your preference on a thin patient with a very visible, very superficial great saphenous vein on the thigh? Would that be lasered, radiofrequency? Would you consider stripping for that one?
I think this is a great question, actually, and this was a controversy initially when the endovascular technique came out, whether the damage to the skin is a concern or not, and absolutely it is. Now, even if the vein is in contact to the skin, okay, you can still give enough tumescence, but the technique is you're going to come in an oblique manner between the vein and the skin, away from if this is the vein and this is the skin, you're going to come this way. Give tumescence here, spread the vein from the skin, and get at least a centimeter or centimeter and a half of fluid in between the two. Okay, now you are safe. The laser energy is not going to travel that distance to heat either the water or the skin, and you should be safe in using both. I would still, in my practice, I use RF about 25% of the time and laser 75% of the time. Honestly speaking, don't ask me why, but I think that patients come in, they want laser. But I think you can, this way, as long as you spread the skin, and that's ABC of endovascular ablation, as long as you spread the skin from the vein by 1.5 centimeters, even to 2 centimeters if you can, you're in good shape.
Which would be your best, radiofrequency or laser?
I would
you know how to use both
my personal preference is laser.
on this situation.
Yeah, my personal preference is laser. But I can't argue against RF. That's my personal preference. Yeah.
Hi all, Mohammed Aysam from University of Miami. I'd like to congratulate you first for this amazing meeting, and it's more a comment than a question. I'd like to ask the pairs committee if in the future you would consider organizing or giving more time to speakers, such talented speakers like Dr. Badran, for example, who has things to say, and we, traveled so far to listen to him. Are you considering giving more time for special didactic, lectures? Thank you.
Thanks for the comment.
This is a very good session regarding this all kind of versatility or kind of diseases. I like to comment on the role of foam in sclerotherapy in venous insufficiency. I've been to 1 or 2 or 3 clinics in Germany. We're shifted now more to the foam than the laser and the radiofrequency. One of the biggest ones, the Angio Clinic in Switzerland and Germany. And the combined laser with the foam, they put a laser because of the pain a little bit at the proximal part near the saphenofemoral junction, then they continue with the foam. And this is less expensive and at the same time more comfortable to the patients. I wish if anybody would comment on this and say what's the role of foam now, because it's more in the fashion than the other techniques. Number 2, I'd like to thank Dr. Badran for his lecture. It's a very, very informative one. I wish, like my friend said, if it's extended more, because there's a lot of knowledge that should be distributed to people, because it's a very common problem that's no solution for this problem rather than to do endovascular treatment by all its kind. My question to Dr. Badran, what about the Klippel-Trenaunay syndrome? Do you treat this Klippel-Trenaunay syndrome? Do you treat these cases, and what is the success rate? Is any tricks in this? Because I find too much difficulty in treating these patients.
We have a large number of Klippel-Trenaunay syndrome, which we treat. And you said, number one, the most important thing in treatment of Klippel-Trenaunay syndrome is stockings. Definitely stocking. This is number one. You have to view the patient as a whole. The second thing is you need to understand exactly what the patient problem is, because many patients, the main problem is not really, the way their leg looks. His main problem is bleeding. So I find in a very large number of these, doing laser, I wish I could show you the video, but if you do laser, just the one from the EVLT, you just laser your way into the vein, dermis. It works very well. If they're bleeding from dermal venous malformation, just like sclerotherapy of varicose veins, you just do 0.5% polydecanol. That works very well. It's essential in all of them. You must do a venogram. It's essential, because what you want to do is make sure you have deep venous system. If you do, you want to kill the extra veins, especially the lateral marginal vein, because it has very high risk of causing thrombosis, and later on it will lead to massive pulmonary emboli and increases with time. Therefore, if the lateral marginal vein is not essential drainage part of the deep system, you close it. And in my experience, these are large veins. I tried EVLT, with compression. Compression doesn't really work a lot because there's a lot of hard lymphatic tissue. It doesn't work.
Tumescent anesthesia.
It doesn't work. I can tell you it doesn't work. So you're going to need to be inventive. You need, if it's very big vein, you need to put a lot of coils, glue, foam. And the problem with stripping these is that you have 1,000 communication with deeper veins. You're going to have a lot of veins. The other thing is these people who have coagulopathy. They are prone to have localized intravascular coagulopathy. With a lot of work, you can progress to DIC and have a patient like that. So you need to be, working gently, gently and progressively.
Yeah.
I'm going to comment on your first question, actually, and I'm glad you brought this up. I cheated myself into this technique as I reviewed an article for the CVIR, as Dr. Kutubi sent to me to review, so thank you for teaching. And actually, the idea, the authors did a great job on that, and I think I approved that paper. Obviously, it got published, though. But anyway, the idea actually is, it's clear that varicosities come off the main trunk, of the saphenous vein. As you're lacing, you're injecting foam slowly. You are really filling those into sclerosing agent, and it works beautifully. In my practice, though, and I don't know if Lebanese women are, and I see, I go to Atlanta, I practice for 2 weeks, I come back to Beirut, I practice for 3 weeks, and I see a major difference in the paradigm of patients. In Lebanon, they want to walk into a vein clinic, walk out, that's it. In Atlanta, they accept the fact that you can do a segment, a stepwise treatment and all that. So this is why I do more phlebectomy in Beirut than I do in Atlanta, and more foam in Atlanta than I do in Beirut. So.
Sure, this is the right answer for the question. I mean, the mentality of our patients rather than in the West. Yeah.
The comment in vascular anomaly. Dr. Badran leads a vascular anomaly program at Kingfisher Specialist Hospital, and the technique Mohammed said, and it's not very difficult to do. It's that you need to have a full setup. We have Mohammed has a clinic, he has a coordinator with the plastic surgeons, the communications. He goes to the dedicated vascular anomaly meeting, the ISFA, and there's a lot of things to do, not only the procedure. So, and like Mohammed said, very common disorder, and you're going to see it in your country, but to do that, I encourage you to have the full vascular anomaly program, and it's not difficult to do.
I quite agree. I have to read a lot of them. Dr. Aguiad, you said that the foam is expensive. I mean, the glue. I mean, with the varicose veins, I use the glue always. And it's much cheaper than the coils, because if you're going to put a set of coils, like 6, 7 coils, they will cost you a lot of money. But with the one ampoule of Histoacryl would go through the whole vein, and it cost you something like £100 or something like that.
Ahmed, I think what your comments reflect the variation in practice, which are all acceptable. I mean, if you look at the literature, you will find many publications, as I said, starting with hot contrast many years ago, going towards glue and coils and things. My personal preference is to go for coils simply because I think you have better control over the coils. I mean, the placement of the coils and things is more precise and more controlled. The problem with glue or with foam is that any liquid material, in my view, is that you have slightly less control on whether it's going to reflux into unintended locations or embolize proximally.
Yeah.
Of course, in experienced hands like your hands and Abbas, this is very extremely unlikely to happen, but still a word of caution to our colleagues that if you're starting this program or you're intending to change your treatment, be aware of the possibilities with this. And I think, combination therapy, I mentioned it in my slide, is perfectly acceptable. Coils alone, and the incidence of recurrence seems to be pretty similar, actually, no matter what method you use. So thank you for your comment.
Thank you very much.
Always the word of wisdom, Aghed.
Yeah. Thank you very much. Thank you for the speakers. Thank you for the participants. It's been a pleasure to have you all on board, and we hope to see you next year. Thank you very much.